all the traumatic injuries. Right side is even rare. That is because the liver is guarding the right diaphragm. However, when we see the diaphragmatic injury, that is a marker of the severe injury associated with other organ damage in the vicinity, that's in the thoracic and the abdomen. In general, about 2/3 of the diaphragmatic injuries are due to penetrating injury and probably with stab or gunshot injuries. Only about 1/3 of diaphragmatic injuries are due to blunt trauma. The diaphragmatic injuries tend to miss in most of the time because they are very small in size. Sometimes there may be large diaphragmatic injuries. In that case, it will be clinically obvious and probably we may be able to pick up in early stage. Straight away, we'll get into the case scenario. My patient is 29 years old male patient admitted to the district hospital following an elephant attack somewhere around 6:30 p.m. On admission, the patient complained abdominal pain and shortness of breath. And according to the information in the sheets and at the presentation, patient has no major injury other than the abrasion in the right side chest and the abdomen. He had no extremities injury and he had no head injury. After the initial assessment and the resuscitation, patient was transferred to us. So we received the patient somewhere around 9:15 p.m. On admission, his complaint was shortness of breath and abdominal pain, the same complaint what he had at the peripheral hospital. So once we get the patient, we assess the patient in terms of A, B, C, and D. The patient airway was patent and the cervical spine was protected with cervical collar. Patient was tachypneic with a respiration rate 42 per minute and his trachea was central. And the percussion note was resonant, and we noted that the patients having diminished air entry on the right side, basically on clinical ground, and the patients having pneumothorax on the right side. Patient pulse rate was 104 per minute with a blood pressure of 100/60. He was quite conscious and rational, and GCS was a 15 out of 15. As patient complained abdominal pain, we went ahead with the abdominal examination. There we noted that there was an abrasion in the right upper abdomen, and on palpation, patient had diffuse tenderness with guarding. He had no major extremity injury other than the few abrasion, as I mentioned earlier. For the resuscitation-wise, we set up 2 IV line with a whiteboard cannula, and the necessary blood was taken for the investigation, including grouping and cross match. On clinical ground, we placed the right side IC tube, and there we noted that the bubbling air bubble in the bottle, which confirmed our clinical diagnosis of pneumothorax. Patient was improved symptomatically. I mean, the shortness of breath was improved with IC tube. Thereafter, we gave oxygen through the mask and catheterized the patient. And in the meantime, we organized fast scan, which revealed little free fluid in the abdomen, but they haven't commented on the main organ, especially liver and the spleen was not commented. So with this background, I took this patient to the ward and kept the patient on strict observation. And there we noted that though the patient's shortness of breath was improved with respiration rate was not improved, that was fluctuate between the 40 and 46. In the meantime, the patient was oxygen dependent. And very interestingly, and the patient's circulatory systems, deteriorated. That is, patient developed tachycardia and hypotension. Basically, patient had tachycardia and hypotension with tender, rigid abdomen. That was quite enough for us to go ahead with the laparotomy. Because unfortunately, the hospital where I worked and had no CT facilities to assess before we embark on the laparotomy. We did the laparotomy roughly about 2 hours after the admission. So these are the laparotomy findings. And patient had large bowel injury, mainly transverse colon, jejunal injury, and pancreatic contusion. And excitingly, this patient had right dome of the diaphragm injured with liver herniation into the thorax. So once I noted that, with the permission of the anesthetist, I went ahead with the thoracotomy. These are the pictures of the pictures taken during the surgery. And in fact, if I have the pointer, I tried with the pointer, but unfortunately that is not working with these digital things. And you can see jolly well the diaphragmatic laceration and the gallbladder through the lacerated wound. And right lobe of the liver was in the thorax and left lobe is in the abdomen. So here you can see the diaphragmatic injury very nicely. So with the permission, I went ahead with the thoracotomy. These are the pictures. This is one of the pictures I took during the thoracotomy, where you can see the lung tissue and the and the liver. So after dealing with each and every injury, I admit the patient to the ICU. There we gave the ICU care for 27 days, and the patient was discharged on 37 days. In conclusion, even though rupture of the diaphragms due to blunt abdominal trauma is rare, the presence of it is very significant. Unless we identify it timely, we might end up with a complication and devastating outcome. Especially in this case, what the take-home message is, the rare possibility of diaphragmatic rupture should be kept in mind when you place in the chest drain on a blunt abdominal trauma patient. The point I want to highlight, when you place in the chest drain, you have to take all the precautions not to damage the underlying structure. Especially in my patient, the liver was inside the thorax. Just in case, if you just put the IC tube, sometimes the tube may be inside the liver. And if that happens, patient might bleed to death. So that is why I said that most of the time we get the trauma patient, the trauma is there. So what we do, we handle that whatever the damage there. But very important to see whether we are minimizing or we are preventing the secondary injury once we're dealing with the trauma patient. So in the patient needed IC tube. So when you're placing the IC tube, we have two types of IC tube in the hospital setup, that IC tube with trocar and IC tube without trocar. In general, in trauma management, we advise medical officers to use the IC tube without trocar because there's a high chance of damage with the trocar IC tube. Once we dissect the thoracic wall, we use the finger to create or dilate the tract, so that if there's something underneath the parietal pleura in the pleural cavity, we can feel that the whatever the organ. So in that case, we can take precaution, and say there we can safely introduce the IC tube. So you can see in the upper pictures, we are just using the finger to do the blunt dissection. Thereafter, introduce the IC tube with the forceps and without any problem. But on the right down and the left side of the down screen, you can see the IC tube with the trocar. So these are the IC tube with trocar. Just in case, if you're using the IC tube with trocar, what we do, we make a small skin incision. After that, we just push the IC tube with a trocar. In that case, once the tissue is given away, so there is no resistance. So the IC tube, then the trocar will go and damage whatever the underlying structure. In my case, and there's a high chance of damaging the liver. So that is why one of the important things our hospital setup is try to prevent or minimize the secondary injuries when we are dealing with the trauma patient. So always in trauma setup, we suggest IC tube without a trocar, but this sort of IC tube with the trocar is good for the battlefield. This is the end of my presentation. If you do have any questions, I'm quite happy to answer.
Thank you, Dr. Besinger. You finished well in time with giving us 1.5 minutes extra, in fact.
Yeah.
So any questions, please address to Dr. Besinger. So judges have any questions?
PAS scan before the laparotomy?
Yes, we did a PAS scan before the laparotomy, but unfortunately in our setup that was done by the medical officer, they just mentioned that there was a little bit of free fluid, but they didn't comment on any organ.
Okay, in the absence of any other questions, we will move on very quickly to the next presentation.
Yeah, thank you very much, actually. And this picture says, if you just go ahead with the normal, the suggested protocol, if you follow the protocol, you can have a good sleep. Otherwise, you may have to get up time and come and see the patient. Thank you very much.
Thank you. And our next presentation is on the epidemiological patterns and trend analysis of human rabies in Sri Lanka, 2013 to 2022. Dr. P.D. Vijayaratna with co-authors Pimuruge RPM, Jayasinghe DN, Kitsiri LD, and Taraka TSP.
Very good afternoon. Until presentations come, I believe you all know dog bites or animal attacks are one of the most commonest injuries reported in Sri Lanka. Can you guess how many dog bites take place in Sri Lanka? Well, actually, we estimate around 250,000 to 300,000 dog bites to be take place in Sri Lanka per year. Per year. So, in this presentation, we go beyond the dog bites and look into a fatal viral disease, which is primarily transmitting by mammal bite or rabid dog bite. So we are going to talk all about rabies and rabies epidemiology. Rabies is a neglected tropical disease which is primarily affecting warm-blooded mammals. And also this disease doesn't have a cure. So whoever person who develop clinical symptoms end up with fatality. In Sri Lanka, annually we observe around 25 to 30 human rabies deaths each year. But this is only the tip of the iceberg because, as we know, according to the injury pyramid, the most preventable part is below the sea. If I can, according to injury pyramid, there has to be hundreds or thousands of people who are exposed to rabid animals still not receiving post-exposure treatment. There will be 10,000s of people who are having near misses or having risk behaviors. On the other hand, apart from the public health concern, rabies has a huge economic impact because government annually spending millions of rupees just to purchase post-exposure treatment. Having said that, we also have to acknowledge there are very effective and evidence-based strategies we can apply to prevent rabies and also to eliminate this disease in countries. Sri Lanka has adopted most of these strategies, and according to the Sustainable Development Goals, we have set our goal to eliminate dog-mediated human rabies deaths by the year 2030. But in order to achieve this, as a country, we should have a clear and thorough idea about the rabies disease and its epidemiology. So in this study, our aim was to describe the epidemiological patterns and trends of human rabies deaths reported between the period of 2013 to 2022 in Sri Lanka. So start with the methodology. This is a cross-sectional study carried out using secondary data extracted from the National Rabies Surveillance Database managed by the Public Health Veterinary Services of the Ministry of Health. Since national campaign is receiving data across the country, study setting include all 9 provinces. During the study period of 2013 to 2022, there have been 250 laboratory confirmed rabies deaths. But in the surveillance system, there were 213 investigated cases, and we also look into their death investigation forms as well. And all these 213 cases were analyzed. With that, we'll move on to the results. First, to start off with the distribution of the disease, we found that rabies cases have been reported from all the provinces. Even if you pick a particular year, still rabies cases were reported, minimum one case per each province. However, when we narrow down it to district level, there have been still there are some districts such as Nuwara, Ampara, where there have been no rabies deaths. However, districts like Kurunegala, Gampaha, and Jaffna were the districts reported highest number of rabies cases. Then we considered the population in these districts and analyzed the rabies deaths per 100,000 populations. During that analysis, we could not identify a significant disparity across districts. Moving on to the rabies cases, majority of the cases were males. And when we look at the male to female ratio, it was 3:1. This difference was statistically significant. And also, in some years, this ratio has been even 9:1 as well. Interestingly, we found majority of the cases belongs to the age category of 15 to 59. Why this is important? Because when we look at the international literature and global data, it clearly states that most vulnerable group is children less than 15 years. But the context and epidemiology pattern is different in Sri Lanka. Apart from that, we look into their occupational categories. It was found that majority were either laborers, cleaners, street vendors, or construction workers who has been mostly working in outdoor settings. Apart from that, majority of the victims were informal sector people who are sole breadwinners, plus they were working, over 60% of people were working for daily wages. With that, we move on to the animal source. In line with the international literature, even in Sri Lanka, rabid dog is the primary source of transmitting rabies to human. However, interestingly, we found out that nearly 25% of the animals who transmitted the disease were puppies. This is important. We further look into this death investigation forms. We realize these particular victims has grossly underestimated the potential risk of transmitting rabies through puppies. So this is an important point we found. Apart from that, with regard to the responsible rabid animals, over 95% were not vaccinated against rabies. Moving on to the host, to start off with the injury site, the foot and toes was the commonest injury site. Second goes to the hand, and third place goes to the face injuries. Unfortunately, we observed that over 80% of the victims have not gone to hospital following the animal exposure, which was an unfortunate thing. And on the other hand, we identified there were 37 individuals who have gone to hospital following the exposure, still developed rabies, of which majority, despite they go to hospital, their compliance for post-exposure treatment was not good. On the other hand, there were very few people, despite they have completed the entire post-exposure treatment, still they developed rabies. And it was observed that in most of these cases, they had major face bites during their exposure. We further analyzed the association to calculate the incubation period, where we calculate the interval between the animal exposure to onset of symptoms. And it was found to be 2.6 months. Further, we were curious to investigate whether there are any association between the exposure site to the onset of symptoms. But we could not find any association between that. Finally, we carried out time series forecasting to predict what number of cases we could expect it in upcoming years. And it was found to be something around 25 to 19 cases in upcoming years. This study has several limitations. Firstly, we depend on secondary data. Thirdly, we observed that most of these death investigations were carried out following the demise of that individual. Hence, information was taken from a third party, and there were some gaps in the death investigation forms. With this, we move on to the conclusion. First, regarding the distribution of the disease, rabies cases were distributed across the country, representing all provinces. Hence, there are no rabies-free provinces in Sri Lanka. Most vulnerable group was economically active adult male who belongs to low socioeconomic backgrounds. Regard to animal source, rabbit, unvaccinated dog was the primary source of transmitting infection, and majority of the cases has not received post-exposure treatment following the animal exposure. With regard to recommendations, we recommend, especially from the national campaign, to revisit the death investigation process and death investigation form so that we can include some additional data which will helpful to us to understand, have a better understanding about the disease epidemiology, or to assess whether there are any gaps in service provision. Further, we recommend to develop targeted interventions targeting this vulnerable group to increase their awareness plus their health-seeking behavior. These are the references. Thank you very much.
Thank you, Dr. Vijayaratna. Are there any questions from the audience?
Usually what happens is that all the rabies cases, eventually once they develop clinical symptoms, they go to hospitals, all the cases. So at the hospital, based on their suspicion, if they suspect if it could be rabies, then it is mandatory to conduct post-mortem and send brain samples to MRI. And there they confirm whether it's rabies or not. It was done post-mortemly. And usually the areas reported in the sample sending is the hospital where the death take place. Yeah. No, madam.
You are given a couple of minutes, don't worry.
No, madam. What happens is, following that notification, we conduct a death investigation. So there we trace where the patient is and where this exposure took place as well. So in that process, we ultimately consider the district as the exposure district. So during this period, there have been no deaths from Nuwara and Ampara district.
Yeah, I have a question. It's really all these investigated dates about 213. All the cases so belongs to rabid dogs or any more sort of causes, other than that rabid.
Yeah. Not only rabid dogs, there are other sources as well, including there were some jackals, bandicoot, and other animals also there. Cats.
Cats,
Yeah. There were 3 jackals, civet cats, mongoose, bandicoot, and there were several unknown stated because we are investigating after their death. So by the time if patients died, nobody know who bite. So there are a number of unknown cases. Yes. Generally, considering each year, males are more vulnerable. Generally, during this entire period, ratio was something like 3:1. But there are some years, male to female ratio of 9:1 as well. Most of the females affected were housewives. Yes, madam. Yeah. Usually, I mean, most of the cases of following domestic animal bites in Sri Lankan context, there are very less amount of stray dogs. Most of the dogs are sometimes they have their owners, but they are free roaming in the community. Yes.
Okay, I think time is over now. Thank you very much, Dr. Vijay Ratna.
Thank you. Thank you.
So the next speaker is Dr. Premadasa, SNB. The title is The Assessment of Injury Surveillance System at District General Hospital, Gampaha, Sri Lanka. It's over to you, Dr. Premadasa. It's now.
Good afternoon, everybody. This study is about the assessment of injury surveillance system at District General Hospital, Gampaha, Sri Lanka. So outline of my presentation is the background, objectives, methods, results, finally the conclusions and recommendations, and some of the reference. According to the World Health Report, injuries are the leading cause of death, hospitalization, and disability worldwide. So injury-related hospital admissions, which account for 17 to 18% of the major hospital admissions in Sri Lanka, and is a major burden to the health system of this country. So WHO estimates Sri Lanka lost about 32 individuals due to the various type of injuries every day. So therefore, the injury surveillance system was introduced in 2016 due to the lack of injury-related data for health planning and management. So this online system captures all injury-related admissions, outpatient visits, and injury-related deaths from base hospital and higher level institutions. The injury prevention unit, sorry for the printing mistake, Ministry of Health is the national focal point operating injury surveillance system, and the medical officer NCD coordinate injury surveillance system at the hospital level and the regional director of health service level. So this is the injury surveillance process. Once the injured patient is admitted to the hospital through the entry points, this may be OPD, ETU, PCO, A&E, and injury formats attached to the BHT. The format is filled by the doctor who sees the patient, and format are kept at the judicial medical officers level. And these filled formats at the wards, units, and JMO office should be sent to the medical record keeping officer or the MONCD in the institution. All these data are entered to the surveillance systems, and the quarterly returns are sent to the RDHS office or the national focal point at the NCD unit, Ministry of Health. And these data were review of injury at these injury data were reviewed at national level and subnational level as well. So once this the information is available, so these are utilized in for the planning and management in the health system of the Sri Lanka. When we compare the outpatient department and electronic indoor mobility returns report injury-related admission in 2021, there is a discrepancy between the OPD reported injury related admissions and the IMMR reported injury related admissions. So some of the quarters OPD reported admissions were high, and some of the quarters EIMMR reported injury related admissions were high. So there is a clear discrepancy between the data in both entering the data. When you analyzed in the surveillance formats attached to the BHTs in different units in the first few months of the 2022 of the District General Hospital Gampaha, we can clearly see that most of the BHT, the injury formats was not attached. The objective of this study to assess the injury surveillance system at District General Hospital Gampaha, Sri Lanka. So we have used the qualitative and quantitative methods, review of the secondary data, manuals and guidelines, and also the key informant interviews with the National Coordinator Injury Surveillance, NCD Unit, Ministry of Health, and the Director, DGH Gampaha. And also we had a focus group discussions with the medical officer NCD unit, medical officer and statistic units, and nursing sisters of ETU, surgical units, injury patient admitting wards, and medical record keeping officers. And it also observed the injury reporting process at the different unit in the hospital as well. These are the problems identified in the injury surveillance system, District General Hospital Gampaha. So one is underreporting of all type of injuries at the hospital and the quality of the data, and there is a poor coordination between the injury surveillance stakeholders. Then these problems were further prioritized using priority metrics, the impact, feasibility, and urgency. And underreporting of all type of injuries at DGH Gampaha was selected for further analysis, and the fishbone analysis was done under 4 arms: system and procedures, materials and methods, health staff, and administrative and management. Under system and procedure, most of them are not follow the guidelines, and poor reporting process and lack of coordination, and there are some gaps in the flow of information and lack of sustainability within the systems. And materials and methods, sometimes the formats are not available, and the misplace of some of the formats, and some of the officers complain about these formats are too complicated to fill, and this is the COVID time, and there are some competing priority during that time, so that is why some of the doctors will not fill these formats. And under health staff, the attitude is the main issue, and poor supervision and by the consultants, especially the house officers, and high workload some of the units, and lack of training and awareness, and sometimes there is no designated medical officer NCD units, and high turnover of the medical officer is also a root cause for the underreporting of the injuries of at DGH Gampaha. And administration and management not use the data for planning purposes, especially in annual planning. Most of the time these data were not used, and no reviews at the hospital level, and lack of supervision and the poor reporting culture within the organization also contribute to the underreporting of all type of injuries in Gampaha Hospital. Key finding of the study: underreporting and notification is one result, and the quality of the data, timeliness and the completeness and the accuracy, and lack of analysis and utilization at the hospital level, and finally the minimal patient engagement. In conclusion, there are issues with the quality and the quantity of injury surveillance data in District General Hospital Gampaha, and data were not utilized in supervision and evaluation processes, and therefore the staff motivation and engagement was less in injury surveillance system. These are some of the recommendations. In short term, so conduct the regular awareness and training, and monitoring and evaluation of injury surveillance system at the hospital level, and utilize injury data in hospital annual planning purposes and develop a coordination among engineering managing clinical staff and the medical statistics unit staff. In long-term recommendations, to develop a no-blame culture, reporting culture within the organization, and introduce an electronic information systems that support the injury surveillance at the institutional level. So these are my reference. Thank you.
Yeah, I think we have got, okay, right. Yeah, nearly 1 minute for questions.
Yeah, all with all the staff together, and yeah, all staff categories. Yeah, from the focus group discussions. So they have proposed, and they have discussed about these are the areas, and then according to that main areas, so we have developed this root causes analysis for each and every like administration and management, and likewise. Yeah.
I have a question. It's really, you mentioned that there's a complexity of the reporting format, or how do I really explain about that? Whether it's a ministerial format or whether it's the hospital.
Yeah, no, it's a ministerial format because if you send a very simplified form, whatever the reporting purposes, it is very easy to fill the formats and send it to through the surveillance system. So otherwise, most of the time they are filling a few lines and keep it in the BHT, so the data is not fully. We cannot capture all the data within that format.
I think we need to understand the complexity of the injury types. Really, you get many kinds of injuries. So when you make a form, it's sometimes very much difficult to have a unique type of commonly agreed one. So as you mentioned that we need to do some survey and they update the form accordingly.
So I think I have discussed with the national coordinator also regarding this one to simplify this format. So after done this case study, and I think he's in the process of changing this format to a simplified version.
Okay, so I think the time also, and thank you very much, Dr. Premadasa. So the next presenter is Samara Vikrama D.I. He's a presenting author. The title is a descriptive study on characteristic of disease transmitted through animals, environmental health aspects in northern naval area. So who's going? That's great. Okay, thank you very much. I think so. We have got only 3 presenters today, one in absentia, but I think all in all, we have got very good case presentation. The first one is the rupture of the right hemidiaphragm due to a blunt abdominal trauma. Okay, study report, and it's really a interesting one, and especially for the surgical trainees and the surgical arena, when they really look at the patient, they need to really go through the probable cause of the probable injury of the diaphragm as well. The second one is really the take-home message is epidemiology pattern of the trend analysis of the human rabies in Sri Lanka. And there's a huge variety, and I think there's gender bias as well. And there's a more towards that the dogs are really good with female. So not with male, really, it's really 1 in 9. So yeah, really vulnerable for dog attacks. And the third one also really interesting one. I think it gives us a big insight about the improvement of the system, especially the injury surveillance system. So thank you very much for all 3 presenters, and even Special thanks goes to the panel of judge, and it's really Dr. Ishanka and Shireen, and and all the participants. I think we have got a great session, and I think anything you want to mention?
No, I think we have run over time, so we're going to keep it short and sweet and thank everybody for both the presenters, the judges, and the audience as well, because at 2:45 we were supposed to start another session in this very hall. So thank you very much for your attention.
Thank you very much. Let's give a round of applause to all the presenters of this session. Each one of them will be receiving a certificate of participation, and the best oral presentation for this paper session will be awarded at the end of the day after the plenary at the Grand Ballroom upstairs. To present the certificates to the presenters, I warmly invite the chairpersons, Dr. Alan Ludovoy and Dr. Suranga Dolamulla, to come forward. Starting with AHMGB Abhay Singha, followed by Vijayaratna PD, and Nalim Premadasa. We express our sincere gratitude to our esteemed judges for this session, Dr. Ishanka Talagala, Consultant Community Physician, Head Department of Community Medicine, University of Maratua, and Dr. Sherin Balasingham, Consultant Community Physician, National Non-Communicable Diseases. Your commitment to this symposium is deeply appreciated. I warmly invite the chairpersons again to present the tokens of appreciation to our respected judges, acknowledging their profound contribution. Dr. Ishanka Talagala, Madam. And Dr. Sherin Balasingham, Madam. Thereafter, I would like to invite Dr. Ravi Jayawardena, General Physician, Head Poison Information Center, to present the token of appreciation to our esteemed chairpersons, Dr. Alan Ludovoy and Dr. Suranga Dolamulla. Respected chairpersons and judges, before we move forward, let's seize this moment of collaboration and knowledge sharing. I invite you all to join us for a group photo. Yes. As we come to the end of this free paper session 2, I invite you all to be seated for the next symposium in this same hall on poisoning prevention. Thank you. Ladies and gentlemen, esteemed guests and distinguished speakers, welcome to this vital symposium on poisoning prevention under the theme of protecting lives, preserving health, advancing strategies. Today, we come together with a shared commitment to explore innovative approaches and collaborative efforts in this crucial field of poisoning prevention. It is my honor to introduce the esteemed chairpersons for this session, Ms. Vajrapani Karunaratna, Deputy Government Analyst, Head of Toxicology Division, Department of Government Analyst, and Dr. Varuna Gunathilaka, Consultant Physician and Diabetologist, National Eye Hospital. Dear Madam and Sir, over to you.
Right. Last week, the 20 Ravi. All right. So, procedures and English with Sarah. That's yeah, that's it. So good afternoon and welcome. This is the segment of prevention of poisoning. There are 3 speakers in this segment. So each speaker was devoted with 15 minutes for their presentation. And we are starting with the first presentation, that is with Professor Andrew Dawson. He's delivering the lecture theme, Protecting Lives and Preserving Health, Advancing Strategies for Poisoning Prevention. So a little remark about Professor Andrew Dawson. So Andrew Dawson is the Director of Clinical Pharmacology and Toxicology at Royal Prince Alfred Hospital and of the Australian National Poison Register. He is a clinical professor at the University of Sydney. In year 2004, he co-founded the South Asian Clinical Toxicology Research Collaboration in Sri Lanka. He has worked extensively in Sri Lanka since year 2001 in building research capacity and was based in Sri Lanka from year 2004 to year 2009. His active research areas include hospital-based clinical trials, community interventions, and epidemiology, both in Australia and Sri Lanka. Professor Andrew Dawson is online, and it's over to Professor Andrew Dawson for your presentation.
Thank you very much for that kind introduction. Can you see my screen? I'm just checking out, is my screen visible?
It is visible now, Andrew.
Okay, thanks very much. Thank you very much for inviting me to speak on this topic. It's one that's very close to my heart. I regret that I'm not in Sri Lanka today. I had to come back to Australia, but I want to talk about poisoning, which has always been a dynamic problem, but in particular in this century, the dynamics of poisoning have really accelerated, and to a large extent, a lot of this relates to globalization and the impact of the internet, and this presents really big challenges to us in terms of managing and reducing harm. So what I'm going to cover today is I'm going to focus really on three areas: how I think the internet perhaps has started to alter the epidemiology. I'm going to give some examples about how increased promotion through the internet has increased frequency of some poisonings and the global availability, often by using advertising or facilitating distribution and certainly bypassing regulation, and what that might mean in terms of how we might have to make responses both in policy and implementing them. And then I'm going to also touch a little bit on the use of large data sets, some of which are derived from internet surveillance, but other from routine collected data, something that we've been working with extensively in Australia. So when I'm talking about toxicovigilance and routine data, the so-called, and indeed in many parts of the world, is look to coordinate this approach by looking at existing data, and examples would include linking poisoning centre call data to the data from hospital clinical toxicology treatment centre, database, social media data, emergency presentations, ambulance presentations, and such. And so this has been the approach that we've really exploited over the last 10 or 15 years in Australia. And as a part of this, we're currently advocating that many poisonings should identify the disease, because this is probably the way to get the most kind of rapid case pickup. And the reason we need to do this is that the burden of fatal intentional self-harm is huge. This is a picture of the world redrawn to account for the actual frequency of intentional self-harm. And you can see, obviously, that much of Asia is overrepresented, and this by large has been driven by deaths from intentional poisoning with pesticides, something that Sri Lanka has addressed significantly over the last 10 or 15 years. But it always has been dynamic. And pre-internet, this is going back looking at deaths in women in the United Kingdom, and I'm going to give you two examples here. The first is this line here is death from coal gas. So it was frequent. Once it realized that this was causing a lot of deaths, predominantly by people asphyxiating themselves, they removed coal gas from the gas supply, and there was a dramatic reduction in deaths. At the same time, in the next line here, you can see another peak. These were drug deaths, and these were predominantly barbiturates. Again, once this was realized that this was a driver, prescription guidelines, access to barbiturates were changed, and deaths dropped off. So in these examples, we have something we can identify, but we actually have things that we can control by regulation. And that's not where we're at in 2021 in many instances. The other interesting thing about this graph is that despite these large peaks here, the background level of other causes of self-harm doesn't change. And so by and large, self-harm is often opportunistic, and people do not tend to switch methods as much as people often suppose. So means reduction is very, very important. So the first thing I want to talk about is a little bit how we think that the epidemiology has started to alter. And this is my colleague, Dr. Rose Cairns, and she has conducted extensive research and leads this in Australia. And so this is the graphs looking at the numbers of self-poisoning in children and adolescents being notified to the poison centres, and we get about 200,000 calls documented a year. And what you can see here is that there's been an increase from about 2011 in both children and adolescents, and notably that increase is very dramatic in young women and in females, to the order of about 3 times as much. So this really drove our interest about trying to understand what's causing this and what potential interventions we might be able to do. At the same time, or shortly after we had published those papers, a series of other papers had come out from various other countries in the world, all showing exactly the same sorts of increase, predominantly young women, but a fairly sharp increase around 2011. So this was a global phenomenon, we suspected. So the way we decided to look at that, Rose set up an examination of both birth cohorts. And so what a birth cohort is, I'll give you an example in a second, but you follow all the children born in a certain year, and you follow each year as their own cohort. And the reason that we do this is it allows us, by looking at multiple cohorts in sequential years, to see, is there a clear kind of temporal takeoff point that we might be able to relate to some social change in social context or some other events or something in the environment that may have implications for how we may want to address this increase of self-harm and suicide. And so here's an example of a birth cohort here. So if this is a 14-year-old girl who presents in 2014, then she is from the birth cohort of 2000. And so that's an example of the birth cohort. What Rose then subsequently did is she set up birth cohorts looking from 1995 onwards. So in 2004 in this graph, each birth cohort is represented by a different color, and this is the first point that she took. So here are the 19-year-old girls, so they were born in 1995, and here are some children at 5 presenting with poison, born in 1999. And so we then continued to plot all of those age groups to look at what happened to their trajectory and when they would peak. And so you can see that all of these birth cohorts here, up until 2008, 2009, 2010, are largely following a very similar pattern. And that pattern suggests that the self-poisoning peak is around about 16 years of age. This is both in males and females. But then 2011, where we started to see that other data, from 2012, we started getting a shift in the curve to the left. So these younger cohorts were starting to self-poison at an earlier age. And so by 2015, it appeared that we were getting a peak at around about the age of 15. So there's been a shift that we've noted in Australia, but this has been now shown in other parts of the world to a younger age. So it's not just an increase in the rate or the amount of presentations, in particularly in young women, but these are occurring at an earlier age. And we call this phenomenon Y2K. Effectively, why is the year 2000 birth cohort got this accelerated and earlier onset of self-harm? And there were a number of theories that have been generated around this, and in particular, based on some other qualitative work, there's a lot to suggest that the internet has a very important role, or social media, and this includes things such as body shaming, direct internet abuse, in some subgroups, actual groups promoting self-harm amongst peers. So previously, things that might have been confined to an individual schoolyard or a more geographic environment now have much greater ability to spread. And this has really important ramifications in terms of what we might want to teach children about how to address and how to handle such stresses on the internet, if indeed this is the underlying cause. But this is probably the most plausible explanation, at least based on the qualitative research in young people in self-harm. So that's change in the demographic epidemiology. I now want to show you something around about availability. So this is a salami on the left, and this is sodium nitrate, which is a compound used to preserve meat. It is legal. It's used in sausages, curing other meats. It's a legal compound. And as such, pretty easily accessible and really had no barriers to exposure. Then what happened in late 2016, early 2017, a new edition of this book, The Peaceful Pill e-Handbook, which is a book that gives various methods for people to euthanize themselves. And it promoted sodium nitrate as a peaceful way of dying. Now, in fact, what sodium nitrate does, it causes extremely rapid onset of severe methemoglobinemia, which, as you know, methemoglobin doesn't carry oxygen. So effectively what happens to patients is they become severely and acutely hypoxic. They have significant amount of pain and generally will die often within a few minutes, losing consciousness and having a cardiac arrest for which we cannot resuscitate people. I'll come back to some of this data later on, but we started to look at the data here to have, this is just in my state of New South Wales. So in the blue is our national coronial data. So the coroner enters this data once they declare the cause of death. Because of the backlog that can take up for 1 to 2 years. So here we can see a rapid increase of coronial data in New South Wales. The apparent peak in 2020 is probably not real because there's a delay of data entry for these years. But to put this in perspective, this is about twice the number of deaths that we would have from paracetamol or paraquat nationally. At the same time, we could look at our hospital data, and our hospital data, you can see much fewer cases presenting to hospital. And the reality is that this just reflects how highly lethal this poison is, and virtually everyone is dying outside of hospital. Even when the ambulance arrive, it's very difficult to resuscitate patients. Well, it's impossible to resuscitate them if they had a cardiac arrest. If they're severely unwell, you may potentially be able to do it by giving them an antidote in the field. So this book was intended for the elderly, but we actually look at the graphics as a bimodal pattern. And by far, we've got this peak in young people, and those young people were not terminally ill. The vast majority of them had prior psychiatric illnesses or psychiatric diagnosis or history of prior self-harm, whereas the second peak at the, in the 80s was much more likely to be related to chronic disease. And so this is probably an unintended consequence of this book, but this data is out, this information is out there in the internet and unfiltered, and it's very, very difficult to deal with. So some of the things that we did to approach this is we firstly wanted to make sure that we could capture this data a lot more clearly. So we made certain that we were actually introducing new codes so that this was not hard to retrieve, so we could collect data more in real time. We also offered up new treatment protocols, in particular implementing treatment by the ambulance. And we increased reporting from our tertiary toxicology admission centres, as well as our routine surveillance of emergency presentations. But dealing with it is actually quite difficult. If you've got a product that has a legitimate use, that is cheap and that's easily available, then this is not as simple as turning off the gas or getting rid of barbiturates. So we've had to implement continuous online toxicovigilance of internet sites marketed in Australia. Those internet sites, if they're a bit ambiguous about what the purpose is, there is an e-safety commissioner, or we can ask those sites to take that information down. If it's clear that they're promoting suicide, we inform the police and that they can be charged, but clearly this can only work for internet sites based in Australia. Some of you may be aware that at one stage Amazon was selling effectively suicide kits, but not really aware of what they were doing. In relation to further limiting supply. We've changed some of the poisons regulations in all of our states that at least reduces how it can be sold across the counter, but this does not really interfere with the kind of global traffic of this stuff, which you can obviously post very easily. So if customs pick this up, it does fall under other regulatory forms, their industrial chemicals scheme, which does deal with importation. But so whilst we could notify them of the problem, this still comes down to an issue of enforcement, and that's actually very, very difficult, given that someone only needs a very small amount that could literally come in an envelope. Our current major approach for this, which is taking a longer time, is to reschedule the nitrate from Schedule 7 to Schedule 10, which just makes it a poison and means that it can't be marketed at all. And the way we've tried to approach this is to say, well, there is sodium nitrate, which can still be used for preserving sausages and other meat. It does cause methemoglobinemia, but the onset is actually quite slow because the nitrate has to be converted to nitrite in the intestine. So this doesn't get us out of the woods completely, but gives us an opportunity to treat patients. So this is really a good example of how difficult it is when you've got things being marketed directly in the internet, often not even using this name of sodium nitrate. It'll be called the pink salt or other such things. We have a similar problem with recreational with recreational drugs. So recreational nitrous oxide is common in Australia, but it's common all around the world. In these surveys of people who are recreational drug users, between a quarter and a third of people will use nitrous oxide. And the problem with this is that nitrous oxide will inactivate vitamin B12, and in doing so, will cause people to become B12 deficient. And then we are having patients presenting with severe subacute combined degeneration of the cord. They're often using these nitrous oxide 2 to 3 hours a day, and they can very rapidly deplete their B12 and start to demyelinate. They can also have central damage, so that we have psychological injury and certainly some episodes of psychosis. So we've got something that's legitimate use is actually for whipping cream. Obviously, we can use it in anesthetics, and that's all regulated in Australia. But for the legitimate whipping cream use, it's meant to be freely sold, but you should not be able to buy more than 6 of these small canisters. And so we knew it was a problem because we were starting to see some patients in our own hospitals. But it's very interesting to see how a low-frequency poisoning can jump up quite quickly. So these are just calls to the New South Wales Poison Centre. So not every hospital is going to call the poison centre about any poison. That's voluntary. But I'm going to make the point here that you can see the absolute numbers are actually quite low, 1, 2, and so forth for many, many years. But then in 2015, perhaps a little bit, but quite a big jump in 2016. An absolute number of only 10 of calls, but this was something that we subsequently found was often being missed in emergency departments, that people or not really being reported. People were being admitted under neurology. But one of the things we've been doing is social media analysis, and this analysis here is just looking at Google search trends. We've also got software that will allow us to look at other social media such as Instagram, Twitter, and to look for these trends. And so this looks over here, this is the number of calls, but the trend over time, and it correlates very well with these increases. And the reason, what was actually happening in Australia is people were actively marketing this. There are companies in most major cities in Australia where you can ring up and say at 2 o'clock in the morning and say, I want to make a lot of cake and whip a lot of cream, and they will bring you around 200 canisters of nitrous oxide, all highly illegal, but really hard to regulate. And so we have been moving again to try and alter the regulation of nitrous oxide, increase public awareness, have direct messaging to user groups and other harm minimization methods. But again, an example of what the internet has brought us now, the sort of unregulated, fairly dynamic changes. The other approaches that we had more in general to self-harm go back to our traditional topics of predominantly looking at poisonings from chemicals and pharmaceuticals, which are still a major burden of health. And we've done a lot of data leakage studies, but this is a formal one, again, led by Rose Cairns. The acronym is Pavlova, but effectively, this is a data linkage of about 8% of the New South Wales population, where we can identify their presentations to a range of services, the poison centre, ambulance, emergency hospital, coronial data. We can link that individual patient across all of those data sets. We can look at their prescribing patterns and other information. And we can look at that both for poisoning, but also adverse drug reactions, a range of other events that we're of interest in. And we can do this, and it enables us to look at other potential precipitants and things that we may be able to alter, both by changing access to means or looking at targeting interventions. So, for example, this information we can take down to geographic location, which we've kind of clustered here into rates. And this has told us, in actual fact, that our rates are actually higher for poisoning in some of our fairly remote rural areas. So these are all adjusted for population. So we have rural areas where overrepresented rates, and there's lots of reasons and stresses for that. And again, this is really a familiar story also in Sri Lanka. So this is a kind of one example of data linkage. And so we're using that to look in particular at repeat self-poisoning. In Australia, the rate of deliberate repeat self-poisoning at 1 year is around about 20 to 30%. In Sri Lanka, the work done by a number of people, including Janaka Pushkumara, shows that it's much lower, as it is in other parts of Asia, at around about 5%, to look at death and to look at the methods and to see what we may be missing and what other interventions we may be able to plan. Other data linkage we've looked at, which we've exploited quite a lot, is looking at restriction of pharmaceuticals. So this is just one example, again, led by Rose, probably over the counter coding. But it was being widely and live. So pushback had been removed completely and all only. This is the period where it was removed, and thereafter you can see a fairly dramatic drop in disease thereafter. This graph here, we've split out the low dose, which is in green here, and the high dose, which is 30 milligrams, which was always prescription. And you can see after that ban, there was a significant drop in the target one, which was the low dose, so that had reduced dramatically. It didn't seem to be replaced by people switching and getting prescriptions for 30 milligrams. And in fact, largely the companies just removed these low dose preparations. So this is an example where we've been able to use big data sets, convince the government to make policy change, monitor the effects of those changes, and then feed back to the government. And at one point, the government didn't really want to make this prescription only at all. They thought perhaps the pharmacist would just dispense it. I haven't shown that data, but we showed that that had no effect at all. It really needed to be scheduled up, and similar things for a range of other drugs, pregabalin, some benzodiazepines, all of which showing similar benefit, but importantly able to feed back to policymakers to inform them pretty quickly whether their policies are being effective, and we can continue to monitor to see if other things are emerging to replace those drugs. So finally, the internet's really changed the poisoning landscape, primarily because it's so nimble and it's largely unregulated, and it really does mean that the marketplace is global, and as such, you can move things around, and it's really probably beyond most border controls to really address this, especially if they don't even recognize it potentially as a poison, as was the case with sodium nitrite. So increasingly, we feel that our policy responses require close to real-time monitoring to pick up signals, but also to inform on the effect of any interventions. And our toxicovigilance in Australia has been very much enhanced by the use of these multiple data sets, often with significant data linkage. Thank you very much for your attention.
Thank you very much, Professor Dawson. Any questions from the audience? No questions? Then we will move into the next speaker. Next speaker will be Professor Indika Gavarammana. Professor Indika Gavarammana is a consultant physician at the Professorial Medical Unit, Teaching Hospital, Peradeniya, and senior professor at the Department of Medicine, Faculty of Medicine, University of Peradeniya. Professor Gavarammana became a fellow of the Royal College of Physicians, United Kingdom in 2010. He holds a PhD from the Australian National University in Canberra. He has a special areas in toxicology and works with the South Asian Clinical Toxicology Research Collaborations housed at the Faculty of Medicine, University of Peradeniya. He works with many researchers from Germany, Denmark, and Australia on the subject of self-poisoning. He has many publications on the fields on toxicology and snake venoming, and has an H index of 34. He is a clinical trainer and also supervises many postgraduate research students on toxicology at present. His topic will be holistic approaches of poisoning prevention, emphasizing the importance of multifaceted approach, including education, awareness, campaigns, regulation, and product safety measures. It's over to you, Professor Gavarammana.
Thank you very much. Can you hear me? Yeah, thank you very much. I think thank you very much for inviting me to talk to you today. It's a long title, but I've narrowed it down to holistic approach to poisoning prevention. And I'm going to share with you some of our experiences in managing an epidemic that was when Professor Andrew Dawson came to Sri Lanka in 2004. So I work in three institutes at the University of Peradeniya. That's where I work. That's where South Asian Clinical Toxicology Research Collaboration is housed, where we did most of this work that I'm going to talk to you about. And also Teaching Hospital Peradeniya, where there's a dedicated toxicology unit, where with an ICU, 4-bedded ICU, and there is a dedicated team, a trained team of doctors and nurses who look after patients who come with poisoning. And yeah, thank you. So before we move on, now let's have a look at the global story of suicides. There are about 800,000 deaths from suicide each year. Unfortunately, about 30% of these deaths are due to pesticides. And this the world map redrawn with proportional deaths of suicide, as Andrew showed to you, shows that bulk of these deaths occur in the countries where we live. About 40% of these deaths occur in Asia. Suicide was always there in this country, but since the Green Revolution, when pesticides were introduced to this country, there was a sharp rise in deaths from suicide. Rates increased to 27 per 100,000 population in 1976. And then there was a steep rise thereafter, and it plateaued at about 57 deaths per 100,000 population between 1983 and 1995. So clearly the death rate from poison increased at the onset of the Green Revolution, where unlimited pesticides were imported to this country. In the 90s, we were actually known as the suicide capital of the world. we had about 47 deaths per 100,000 population per year. And there were about 24,000 deaths between 1994 and 96 due to suicides. And unfortunately, about 80% of these deaths were due to pesticides. So poisoning is synonymous with pesticide poisoning in this country. Now, why is this? This was one of the earliest studies done by our group, and it showed that when somebody wants to commit suicide, the agent was found within the home in most of the instances. So very rarely people would go out to a shop and buy a pesticide or medicine or whatever. In majority of the cases, the agent was found within the house. And we also found that there's very little planning, actually. It's, majority of those who took pesticide or medicine or a plant poison, planned very little, maybe under an hour. So there's no, majority of them have this intense desire to kill themselves or attempt self-harm. And then, the agent is found within the house. So I'm sure this would have been discussed in the morning about injury prevention. So this is the Haddon's matrix of suicide prevention. To prevent injury, suicide, you need to, especially for suicide prevention, we need to address these three areas. Better treatment, then we should, as Andrew mentioned in his talk, we need to control purchase, and we could also store them better. And of course, finally, regulation of pesticides, where we restrict access to highly toxic pesticides in the market. So when SACTRAC began its work in 2004, pesticides were imported based on WHO classification of pesticides. There were 4 classes, and these classes they were classified according to the rat toxicity. They did 50 on rats, and even before any data was available in the early 90s, some pesticides were banned just because the clinicians who were looking after these patients thought that they could do very little about some of the pesticides. Most patients who took these poisons could not make it to the hospital. They died at home or they died on the way to a hospital. So some physicians who were treating these patients were feeling really helpless and suggested, I think use media to propagate this, the toxicity of these pesticides, the idea of banning these pesticides. And then the government took it on and banned class 1 pesticides. And with that, you can see there was a sharp reduction of number of suicides in this country soon after the bans. So at South Asian Clinical Toxicology Research Collaboration that are found in 2004, our vision was to reduce deaths and illness caused by poisoning, snake bite, suicide, and self-harm in South Asia. And our mission was to establish Sri Lanka as a regional hub for medical research and professional training in toxicology and toxicology. So we started this large cohort of patient database in several provinces, in leading hospitals, and we recruited all these patients who came with the poisoning. And what we found through this data collection was that the WHO classification was actually misrepresentative. Some of the poisons that were labeled as less toxic were extremely toxic in humans. And we also identified that 3 pesticides accounted for about 60% of deaths in this study. And then we did a little bit of modeling exercise and then showed that if there were no bans, the overall case fatality was 10.3. But if the bans were introduced, and with all those patients shifted to a less toxic substitute, less toxic pesticide, the case fatality would have been even lesser at a 4.7%. Or if they shifted to the highest toxic remaining substitute, it would have been still less at about 7%. And this data was presented to the Pesticide Technical Advisory Committee, and they banned these 3 pesticides. And what was its effects? These bans, the 3 pesticide, paraquat, dimethyl, and pentyl, led to a sharp reduction of pesticide-related deaths in the country. That shows the red boxes. Sorry, the blue boxes show. Sorry. That's right. The red boxes show the pesticide suicide rate, and this is when the bans occurred, and you can see that the suicide rate dropped thereafter. But surprisingly, we also noted that the overall suicide mortality also dropped since the bans were introduced. And one might wonder whether these bans have an adverse effect on agricultural output. These are the agricultural output that we have shown, and there's no reduction in the agricultural output. So this is a success story where we showed that reducing access or banning highly toxic pesticides can bring about a sharp decline in death rate in the country. Then we carried this study forward, and we recruited quite a lot of patients. By the time this paper was published, there were about 35,000 patients. Now we have gone beyond 100,000. And what we noted was that the case fatality of those non-banned pesticides, those are less toxic pesticides, was also reducing. And this may be because of improved care. And to this effect, improving medical care in toxicology services, our group has done quite a lot of work. We have trained about 50 postgraduate students, both in MS, MPhils, and PhDs. We have built research infrastructure in many institutions, including Peradeniya, and we have published numerous scientific publications, over 500 papers, and we keep getting international research grants. So the toxicology knowledge base increased in the country. This our group was able to contribute to guideline development of managing pesticide poisoning management. And there was an MSc toxicology that started by the PGM, and our group contributed. And there was propagation of this evidence through WikiTalks. So all this would have contributed to improved knowledge, and by improving the care provided to these patients. Now, we also wondered, hindering access to pesticides and other poisons at home could bring about reduced suicide rates. So our group, through a research grant, studied whether safe storage of pesticides in a lockable box can bring about a reduced rates of pesticide poisoning deaths. So this study happened in Mahavali H area. We included, this was a cluster randomized controlled clinical trial. To one group, we gave these boxes, and to the other group, we did not provide these boxes. And there were about 225,000 individuals in this study. And what we found at the end was that there was no difference in the case, the rate of suicide due to pesticides in this area. So the Comprehensive Mental Health Action Plan of WHO wanted the set target to reduce suicide rate by 10% by the year 2020. And Sri Lanka has reduced it by 70% through these measures that I told you about. And this is estimated to have saved about 93,000 lives. I think it's about 100,000 lives now. And there was an award presented to Sri Lanka on this achievement. But we need to improve this further. And this is how usually patients present to pesticide poisoning. This is the patient with organophosphorus insecticide poisoning with a lot of froth coming from the mouth. And this patient's lungs are flooded with fluid. And the current management of pesticide poisoning is there is a sprayer, and then he takes his poison and falls sick. Somebody notices this patient being so sick, and his patient is transferred to a local hospital. From there, the patient will be transferred to a secondary hospital. So what we wonder is whether if we could treat these patients in the village itself, by means of, by some means, if you can delay, if you can prevent the delay of this patient getting to a hospital after poisoning. So we are trying out auto-injector, especially for organophosphorus insecticide poisoning. So this is an auto-injector that contains atropine. So we're trying to see with how feasible it is auto-injector to be used in a village in case of organophosphorus insecticide poisoning. So in summary, the holistic approach with evidence, the one that works best is restriction of access to pesticides. You need sound data, sound meticulously collected data, and that such data should be produced to the policymakers, and they will effect bans. And what we propose is to ban all those pesticides that have a case fatality ratio of more than 5%. We should ban all those pesticides, and then we will be able to bring down the case fatality from pesticide poisoning. Then, of course, a better treatment, further education through multiple sources, undergraduate, postgraduate curricula. If we can improve care, we can improve care and prevent deaths from self-poisoning, and of course, improved facilities at various hospitals, ETUs, PCUs, and general medical wards. And if we can have a dedicated toxicology ward in at least one hospital in a province, we might be able to improve care. I'd like to acknowledge a lot of people who contributed to our efforts over the last so many years. Thank you.
Thank you, Professor Gawarammana. We will move into the next speaker and have the discussion at the end of the session.
Unfortunately, I have to go. So I think Andrew will ask all the questions that you have for me. Thanks, Andrew.
Thank you very much, Professor Indika Gawarammana, for your star class presentation. And now we move on to the last segment presentation. The speaker is Dr. Ravi Jayawardena. He is currently the head of the department, National Poison Information Center, Colombo, Sri Lanka. And he has graduated from Sri Jayawardena University. And he had completed his postgraduate training at University of Colombo. And in addition to that, he has a specialized training in acute medicine at Royal College of Physicians, London. In addition, he has worked as an emergency treatment unit physician at Teaching Hospital Karapitiya and Teaching Hospital Ratnapura. In addition, he has worked at Balangoda District General Hospital as well. He had made more than 35 national and international publications so far related to the general medicine and toxicology. So over to Dr. Ravi Jayawardena for your presentation. The theme revolves around effectiveness of poison control centers in mitigating poison incidents. Over to Dr. Ravi Jayawardena.
Good afternoon to you all. Thank you for your kind words from the chair. Right. Since morning, you have been listening to a lot of presentation. I think most of the people now feel drowsy or sleepy. Because of that, I like to, right? Anyway, this is poisoning. Poisoning too much of. This is not the presentation. Hello. Change. Okay, right. I'll be talking about effectiveness of poisoning control and rapid response in mitigating poisoning incidents. During my next couple of minutes, I will be talking about the statistics of poisoning. Actually, my lot of the data already presented. You know about this, and most of the slides that I am going to use already you have seen. And regarding the history of poison center establishment and establishment of National Poison Information Center in Sri Lanka, and what are the functions of the poison center, how poison center functions help to mitigate poisoning incident and health benefit and economic benefit of a poison center. You know, poisoning is a very common problem in Sri Lanka as well as in the world. In 2016, it is estimated that more than 100,000 people died due to poisoning. And it resulted lots of 6.3 million healthy lifestyle. In addition to that, this is poisoning. The snake bites also causing more death in the world. You can see our figures later. And about Dr. Professor Gauramman said approximately about 30% of global deaths due to the suicidal death is due to pesticide poisoning, and this poisoning is one of the major cause for the emergency admissions to the hospital. You may like to see what are the features, what are the figures in Sri Lanka. You have seen global figures. In Sri Lanka, you can see in the early 2000, we had about 50,000 poison cases per year. Gradually, it has grown up. But by 2019, it is 81,000, 30,000 rise. It is rising. After this pandemic, you can see a slight drop, but our prediction is for future, again, it will rise. And this is a huge problem in Sri Lanka. In addition to that, you can see how many patients get admitted to the government hospital following the snake bites. About 35,000 per annum. But fortunately, we don't have much deaths compared to the other countries in the region. You all are doing very well, and because of that, we were able to keep our death rate around 1 per 1,000 snake bites. When we come to the poisoning, why we should need the poison center in a country? You know, the poisoning has very complex chemical scenario, or the lot of chemicals are involved. Some are God-given one, the plants and the snakes, or the other animal causing poisoning. Those are God-given. In addition to that, we have the human as a human, we have created our own one. Those are medicines, right? Those are medicines and other pesticide agrochemicals and some other industrial chemicals and household chemicals. There are more than 60,000 registered chemicals in the market, and there are more than around 7,000 drugs in the market. And there are a lot of poisonous plants, poisonous animals. Any clinicians can't keep those knowledge in their head. And because of that, we need experts to manage this kind of poison. That's why any country need a poison center. When we come to the history of the poison center, we have heard about the poison management in the future and what's the current situation. It's always better to have some idea about what has happened in the past. And we'll start from there. Initially, it wasn't the poison center. It was a first clinical treatment unit, which was established in the Denmark in 1949. They saw a lot of poison patients coming, especially they were using the psychoactive substances, and they make a specialized unit. In that unit, they manage patients. They saw there is remarkable outcome with this unit. Same time, 1949 to 1950, that is after Second World War. Then there was a lot of new chemicals, new drugs coming into market. Then what happened? There were more than 400 children who were dying each year. The medicines they were using, the color and the taste was similar to the candy that we use. And because of that, they were using and they were dying. But there were no experts available to manage these patients. And because of that, they were dying. And people think that if we had poison center, if we had knowledge, we could have prevented this death. Then you can see this historical image. The man is Louis Dalman. He lived in the USA, Chicago. He is not a doctor. He was a pharmacist. Pharmacists who work in this Luke's Medical Center in Chicago. He had very good knowledge about the hazardous chemical, and because of that, when people get with some poisons, they used to call this person. He was very volunteered, and any time he was ready to answer the call. Not only answering the call, he kept a record of these patients and what kind of products, what kind of symptoms these people are developing. And after a few years of work, then with some other doctors, first poison center established in the Chicago. And he was offered the fellowship in medicine in Chicago Hospital. He's the only pharmacist who got the fellowship in medicine so far. After that, since then, there are several poison centers appeared and started because it shows the effectiveness of the poison center management of the poisoning patients. And after more than 100 poison centers started in the United States itself. But after that, some centers amalgamate. Now there are 55 poison centers in the US. There is American Association of Poison Centers. Now they have standardized the management protocol, and they are giving same kind of information and treatment protocol for each and every poison center. Then gradually, other Europe countries, Southeast Asia, also started poison centers. What about Sri Lanka? You may like to hear what happened to Sri Lanka. We have seen this slide already. Before 1960, our death rate was less than 5 to 100,000 population. But since 1960, you can see gradual increasement of this suicide rate up to 24 till 1976. In 1977, you all know, we opened our economy. In the J.R. Jayavarden's era, we opened our economy. With that, there were a lot of chemicals coming to our Sri Lanka without any regulation. There were a lot of advertising happening. And in addition to that, some farmers were given credit facilities and some other intensive to use this pesticide. With that, with the increased usage of pesticide, what happened? The suicidal rate due to pesticide also increased. Then you can see the register of pesticide was appointed. Pesticide regulator committee was appointed in 1979, and we were become the one of the first suicidal, right, or the capital of the, as Dr. Gauramman said, capital of suicide in the world. That is, and after that, this was a huge problem. In 1988, the first poison information center in the Southeast Asia was established in 1988. The founder was the Professor Ravindra Fernando. This is our center, National Poison Information Center. Now we are serving at this center. In addition to that, there is a national international policy framework for poison control center. In UN Agenda 21st, it recognized poison center as a priority. That's in 1992. Still, we have doubt whether our country has recognized poison center as a priority or not. But it's a in UN agenda is a priority. Another thing, global chemical management institution, poison centers were included in the global plan of action. In addition to that, nowadays we are practicing this IHR requirements and WHO chemical roadmap. According to that, it's mandate country to have poison information center and access to toxicological services. Unfortunately, our toxicological service in our country is not up to the expected level. We are trying to build up. Then how this poison information center function? Usually, traditionally, almost all poison information center provide information through the telephones. We provide 24/7 service to the country. Usually, we get calls from the health professional, other professionals, police, schools, and public. Then we inquire about the patient's condition and we give individualized management protocol for each patient. You can see what kind of calls we get. This is about 2 weeks ago. We got a call from a mother. She was very worried about. She was a lactating mother. She had a 9-month-old baby, and she has taken some cough syrup for her cough. And later she found it's contraindicated in lactating. Then she called us and asked, "What will happen to my baby? Should I admit that baby to the hospital? Can I continue my breastfeeding? If not, for how long?" Actually, we looked at what are the components of this cough syrup. It wasn't very harmful, and we reassure her and ask her to stop breastfeeding for 7 months because of considering the half-life of these ingredients. And after that, she didn't get admitted to the hospital. This is another case. That's also the first one. 4-year-old child eating powder, small sachets. This is from Mulatu bacteria. Actually, doctor called to us. Patient came to the hospital. This packet contained iron powder. This small child has taken iron powder. Sometimes this iron powder can cause a problem and iron overdose. Then we advise what to do according to the patient's condition. The third one, this is silica gel. You will see with some peanuts and some other preparations we get. This is non-toxic substance. But after eating this silica gel by a 3-year-old child, the patient has come to the hospital. Then we said this is not toxic, and because of that we can send the home. But we didn't know that the reason was this patient was having cough. After eating this one, patient was aspirated with this silica gel, and because of that, patient needed endoscopy, the bronchoscopy, and remove the this silica gel. This is a video from a yes, right. Sometimes doctors, this is from a ETU doctor. Doctors are in dilemma. What kind of poison is this? Actually, this is a Albatross viper, and sometimes they just send the pictures of these snakes, sometimes pictures of this poisonous plant, and ask from the center what is the poison. Then we advise according to what to do. Sometimes we see the patients online also to the WhatsApp using that new technology, but we don't have this special big boards so far. We are using available resources. In addition to that, toxicology treatment unit, the toxicology center working as a training unit for the whole category of the medical staff as well as the general public. We train medical students, the doctors who are in currently working, postgraduate students, especially emergency registrars. Regularly we are getting this acute medicine registrars trained from the National Poison Information Center. And in addition to that, all three forces who are working in the field, they get regular training from the National Poison Information Center and several other categories. In addition to that, our center do research and publish. I'll come to, there are a lot of publications from our National Poison Information Center. You saw that initially there were a lot of deaths following this introduction of the pesticide to Sri Lanka. During that time, actually, Praveen Fernando and other colleagues has done a lot of research from the Poison Center. It helped us to diagnose what is causing this death in the country, and it was the WHO class 1, the most toxic class 1 category causing more death, and because of that, we were able to contribute to the nation by saying or by suggesting we have to ban those kind of poisons from the country. In addition to that, we conduct our toxicovigilance, we collect data and surveillance also. Initially, before 2000, you can see the most common type of poisons was pesticide poisoning. In early 2000 also, now it has changed. That now trend is household poisoning is causing more death rather than the pesticide poisoning or more cases. Pesticide poisoning remain the third place. Then what kind of inquiries we are getting? Most of the time, it may be pharmaceutical, maybe pesticide or other household poisoning. We are keeping data. In addition to that, as a National Poison Center, we conduct a lot of public awareness program for the general public, as well as every year we conduct the Vision Nivaran Satya, this Poison Prevention Week. Every year we conduct regularly. In addition to that, we made these posters and these handbills and go and educate people about the particular incident if something is happened, especially during this festival season in the river area. You know, carbon monoxide poisoning following this barbecue oven usage is happening regularly, and every year we go and educate these hoteliers, and now the incident has reduced. In addition to that, the National Poison Information Center provide the guidelines. Earlier, before this guidelines, Sri Lanka didn't have any guidelines, and this Poison Center initiate this process, and most of the time they couldn't initial period at maybe beginning of your career, right? Most of the time we didn't have even this internet facilities, how to manage these patients, and it wasn't uniform. Now in Sri Lanka, you can see everyone is using this national guideline. For national guideline, we are contributing a lot. What kind of poisons currently available and what are the available up-to-date management. We have access to the Talkspace UK, and because of that, we can give up-to-date management for our patients. In addition to that, we coordinate for the antidotes and antivenom supply. We know as a center how much available in Sri Lanka, what is not available, and in which area this is available. If someone has any doubt, they can contact the poison center and get the information. In addition to that, we attend to the chemical incident events. You can see first picture. This was from the Homagama a few months ago in the factory storage facility. There was some chemical incident. 3 people died and a lot of people injured. The doctors contact poison center, ask about the management. Then we advise. The recent fire incident happened in the Peta, Colombo, this October 27th. There were 22 people got injured, inhalational poisoning, and 1 patient died. Actually, we manage those patients in our wards. In addition to that, this is a kind of chemical incidents that's happened in Narammal school. There was a competition over the head prefect position, and one competitor has given poison to other 6. They have mixed poisons with the water and asked them to drink. She also has drunk a little bit. Right? Then all got the vomiting and the other symptoms and admitted the Naramal hospital. From there, they contacted us and we gave advice what to do. Already this slide you have seen. Earlier, there were a lot of poison cases happening in Sri Lanka, but with the implementation, this regulation, pesticide regulation, for that also poison center contributed a lot. They find what kind of poison causing more death during this 88 to 89 period, and they suggested what kind of poisons, especially this pentathione and glutathione, right? Methyl parathione causing more death. Then in 1995, whole WHO class 1 poisons were banned from the Sri Lanka. Pesticides were banned. But after that also, this endosulfan, this was WHO class 2 pesticide. It also causing more death. And then this endosulfan was also banned from Sri Lanka. Then actually after that, this SACTRAC team come into Sri Lanka and they did a lot of works. In 2008 to 2011 period, we found this paraquat dimethyl phenthone causing more death in Sri Lanka and helped to ban those substances from Sri Lanka. Now, because of that, we were able to reduce the death rate. Now you can see during last 2 decades how as we are doing as a Sri Lankan. Earlier, there were more than 2,000 deaths annually. Now it has come to around 450, around 500 deaths, because you all are working very well. In addition to that, there are a lot of benefit to the society. There is reduction of patients and family anxiety. And we help to reduce the emergency department overcrowding. Otherwise, some people who shouldn't get admitted to the hospital will get admitted. Then in addition to that, the burden of the overall medical system, we are helping to reduce it. And there are a lot of other benefits. When we compare the economic advantage of the poisoning, cost and benefit ratio, unfortunately from our countries or the similar countries like us, we don't have studies. But from the developed countries, there are studies. What they have shown, the high income countries, every dollar you spend on poisoning help to protect or save $13. That means for $1 now 325 rupees in Sri Lanka. If we spend $325 to the poison prevention activity, you can save 4,500 rupees. In addition to that, there are some studies, it shows poison center service cessation increase 3% of the healthcare expenditure. And it will reduce the death rate, obviously. And in overall, poison centers play a critical role in safeguarding public health and safety, contribute to the management, prevention, and mitigation of toxicological hazard, thus providing significant health and economic benefit. And also, spending in poison centers help to save a lot of money. Thank you very much. And my special thanks to go to all the staff members who work presently in the poison center, as well as the who worked previously in the poison center. Dr. Varuna Gunatilaka, actually, he was one of the former poison center head. Thank you.
Thank you very much, Dr. Jayawardena, for your elaborative presentation. Being we are lagging behind the time, I think that we can devote few minutes to ask some questions from these speakers. Hopefully that Professor Dawson may be online, Professor Gavaramana, yeah, perhaps you may be online, and already the Dr. Jayawardena is with us. So I think a few minutes, I think if you have questions, you can fire it out.
First one is actually we have in this movement we have so many first aid trainers. Then what is the interaction between first aid trainers and what is the poison information center? Because they are always facing some incidents in relevance to the poisoning. Then they need some big informations to give some first aid before what is the attending to that case. Otherwise, they also get some impact with the poison and other things. That is my first question. Second question is, in this movement, actually, in our country, we have so many, what is the indigenous species of poison, like Niangala and other Kaneru, we are calling Kaneru, like that things. And what is the advantages and disadvantages of full awareness of the rural society? Sometimes it may be some disadvantage. According to your study area, is that advantage or disadvantage? Because always we are talking these kind of incidents in with the, as case studies. Sometimes it may be give bad results in future. Then I need to ask another question also. Sorry for give me chance. In this moment, we are facing big issue with the what is the ripening fruits. We don't in Palagood area they are using so many chemicals to ripe the fruits, especially banana and other things. That is a big impact to our society. That also give bad results to our health and other things. Sorry for getting more time. Thank you.
Your first question regarding the training of the first aiders. Actually, with NCD, we are contributing and we are training the first aiders, and we are preparing the guidelines to use in a national wide. That's actually this poison management first aid prepared from the National Poison Information Center, and some training already we have done. For the second one, your question is regarding the some awareness about the especially natural. There are two things natural. One is this plants and other one is snakes. About these animals we can't do anything, but regarding the plant poisoning, earlier there were a lot of canary poisoning was reported in Sri Lanka. During that time it was a passion, because what happened when there was media, it was reporting the newspapers, sometime in the TVs, they were over publicizing this scenario, and because of that, young people used to take more Kaneru. Actually, we advise social media to not to publish this kind of information, especially when we go for the educational program. Also, usually we don't do education regarding this plant poisoning in the school. because then they know this is poisonous and they can use. And most of the time, this is disadvantages, and because of that, we are not advocating that education. The third question regarding this, lot of food ripeners that use in the current market, especially for the food ripen, we use ethylone. That's a chemical that we use. The ethylone is a recommended food ripen to use. But the problem in the poison, there is a good saying, anything in excess is poisonous. If we use adequate amount in a regulated way, that will be fine. But the problem, the recommendation is to put this solution, ethicone solution, into some container, keep it in a room, and these vapors go around the room and close the door after putting this foods. But the people, what do they dissolve that in a spray machine and they just spray. Sometimes there are some tanks also, when they are doing in a commercial level, they just put the banana or whatever the things that they want to ripe, and they put it and take it out. And because of this is not recommended, this this is toxic, and better to avoid those kind of foods.
Thank you. Thank you. I think little thing to add for that now being the role of the National Poison Information Center, it's a 24-hour service with the hotline. So because all the information related to the poison, that you all can get it. So that is the public awareness institution. So then it's open. And the objective of this Poison Information Center in our principle, that we know our limits, and we are not sensationalizing the incidents. Once the poisoning incidents are sensationalized with the media, so the adverse effects come. So it's a negative repercussions come up. So I think that the important thing is to regulate this type of sensationalism. If you see the English media, because they won't sensationalize it. If you are going to the Sinhala media from Divayana, Lanka, and other things, even the headlines are making of, it's a big shout about all these trivial incidents. So that type of things should be deterred. But there are media ethics and guidelines, but unfortunately, these things are not adhered. So I think it's a social responsibility and the media responsibility to curb this menace of this excessive or undue publicity about this poison incidents. That's the one thing. Then second thing is now, because that you have raised about this, plant, that ripening chemical hazard, and Ravi has explained it. But not only that plants, fruits, but even in the rice, that's the same thing. Because how it stored, how it fumigate, how the toxin substance are percolating into the rice seeds, it's there. Because these are daylight things, daylight toxicology hazards. But the issue is, but it was not regulated. So from somewhere, because these things should be paid attention. So these are rice millers, because how they are preserving these things, big mills. So this is also, I think, we need to pay our attention for that. So that is for a added thing for that comment. So thank you very much for your active contribution for this symposium. That one last question I would like to ask from the Ravi, because the thing is that you have mentioned that iron powder in this food packets. Is it legally allowed, or in that, because the silica gel we knew it, iron powder in peanut packs?
Yeah, actually this iron powder used as an oxygen scavenger. It's recommended and used in other countries also. And usually what happens, it's in the ferrous form. With oxygen, it becomes ferric form. Ferric is not toxic. And because of that, we can use that. It's recommended.
Okay, right. I think we are behind the time. I think we can putting down the curtain at this moment. So thank you very much for all these three speakers, Professor Andrew Dawson, Professor Indika Gaurammana, and Dr. Ravi Jayawardena. So thank you very much for your thought-provoking and excellent star-class presentations. So we are winding up this presentation, and thank you very much for your gathering.
Thank you, sir. In the spirit of recognition, I warmly invite our chairpersons, Ms. Vajrapani Karunaratne and Dr. Varuna Gunatilaka to come forward in presenting the tokens of appreciation to our respected speakers who undoubtedly enhance the significance of this symposium. Dr. Ravi Jayawardena, also Professor Andrew Dawson and Professor Indika Gavaramana, we will be sending your token of appreciation and certificate in due course. Thereafter, I would like to invite Dr. Sherim Balasingham, Consultant Community Physician, Non-Communicable Diseases, to present the token of appreciation to our esteemed chairpersons, Ms. Vajrapani Karunaratne and Dr. Varuna Gunatilaka. Respected chairpersons and speakers, before we proceed, let's seize this moment of collaboration and knowledge sharing. I invite you all to join us for a group photo. We appreciate your valuable participation and we look forward to continuing this momentum in the upcoming session. As we bring this session to an end, I invite you all to join to the grand ballroom upstairs for another productive plenary session. Thank you.